Hi, good afternoon, everyone. So nice to see you all. Thank you for joining us for our sixth session of the Child and Family Focused Learning Community, which will be focused on quality and reporting and meaningful outcomes. For those of you who don't know me, which hopefully you do by now, I'm Sam Holcomb. I'm the director of the CCBHC Expansion Grantee National Training and Technical Assistance Center, and I'm a senior director at the National Council for Mental Wellbeing. Go to the next slide. As a reminder, just going into this session, this series is being sponsored by SAMHSA through the CCBHC Expansion Grantee National Training and Technical Assistance Center, but its contents are solely the responsibility of the authors and doesn't necessarily represent the official views, opinions, or policies of SAMHSA or HHS. Next slide, please. So as we move into the session today, there are really two key elements of the CCBHC criteria related to quality and other reporting, that being the clinic's ability to capture, report, and leverage data related to consumer characteristics, clinical processes, and outcomes, as well as development and implementation of a data-driven continuous quality improvement plan. You're also probably very aware that SAMHSA or CCBHC required reporting does currently vary by funding mechanism, right? So for demonstration clinics, they're reporting alongside their states on the 21 CCBHC quality measures, while grantees, although needing to build the capacity to report on those quality measures, are currently really reporting on the SAMHSA NOMS and IPP. That being said, today's focus is going to be really at this broader systems level. It's thinking about the best practices in children's behavioral health data collection, reporting, and quality improvement approaches, and how to use the data to drive improvement in the delivery system. So we're going to be focusing on that lens and thinking about how you align those with your work as a CCBHC. Next slide, please. So as standard for all of our sessions in this learning community, we have a mix of expert presenters at the national, state, and clinic level. And we'll start by first discussing national level themes and best practices. And then we'll dive deeper into, I always think about these as case studies, right? Looking at the state and clinic perspectives from Tennessee today. So I'm so excited to be joined by these presenters today. We have Jeffrey Vanderploeg, who is the president and CEO of Child Health and Development Institute, an organization focused on improving the health, mental health, and early care systems for children in Connecticut. We also have Terry Virgo, who is the director of the Office of Children, Young Adults, and Families from Tennessee's Department of Mental Health and Substance Abuse Services. And then we have Mandy Ryan, who serves as the VP for Healthcare Integration at Centerstone, which is a behavioral health organization that operates in Florida, Illinois, Indiana, and Tennessee. They operate CCBHCs in all 4 of those states, and Terry's focus today is on their work in Tennessee. So I'm going to turn it over to Jeff to kick us off. But before I do so, just a brief reminder, we want this to be as interactive as possible, and this is really your time. So throughout the session, when questions come up, please just place them in the chat. We're monitoring them, and we'll get to as many of them as possible at the end of the session. And Jeff, you can take it away.
All right, Sam, thank you. And I should say, I don't know if you're the one to thank for that jazzy music introduction that we all enjoyed as we were waiting for this to start, but that was a real toe tapper. So it makes me feel energized to get this conversation started. Thank you again. My name is Jeff Vanderploeg. I'm the CEO at the Child Health and Development Institute, located in Farmington, Connecticut. And Sam, I can't take credit for that. Okay, well, somebody can. I'm going to start today just by going through the learning objectives, talk to you a little bit about some of the work that we've done here in Connecticut and with other states that have helped us to gather a sense of best practices at the national level that relate to the CCBHCs, but also just general system building, what kind of information you want to collect as a state system that are just represent best practice. But what I'm really excited about is turning it over at some point to Carrie and Mandy, because what they're going to do is share with you some very specific examples of the work that they're doing in Tennessee through their CCBHC initiative, but also at a state level. because I think it's going to really generate a lot of really interesting and thoughtful ideas for you all as participants in CCBHC. And again, as Sam just said, opening up dialogue and conversation so that you can interact with them and learn from their experiences. So first of all, today, just in terms of learning objectives, we want to identify alignment of the required measures with Medicaid child core measures. We just thought that was an interesting point of opportunities for alignment. Also, as I mentioned, we'll talk about the national landscape and best practices in children's behavioral health data collection, reporting, and QI. And then Carrie and Mandy really take over on the last two, learning how a children's behavioral health system design and investment in quality at the state level can support your CCBHC QI initiative, and also how one particular CCBHC uses data to drive those system improvements. Let's go to the next slide, please. So as I said in the first bullet for the learning objective, there are a number of required measures that are part of the CCBHC initiative for the demonstration clinics. I also understand that there are a number of participants on the call that are grantees and are responsible for NOMs, but as we look at this list, even for those of you who are grantees, these are opportunities for you to build capacity towards collecting this kind of information as part of the CCBHC initiative. And the other thing that I thought was interesting is where there are areas of alignment between the CCBHC required measures and then the child CMS Medicaid child core measures. And even outside of this list, there's probably a whole number of things, either at the program level or at the state level, that you'd be interested in collecting. So one of the major take-home points here is not just to go through this list bullet by bullet, but it's really to say, where are your opportunities for aligning across your data collection requirements that you have in your various initiatives? How can you kind of put these whole lists together, working together through your CCBHC initiatives, but also with other priorities that you have as a state or as a community around delivery of behavioral health services for children? And how can you make sure that you're being as efficient as possible in how you're collecting this information? Let's go to the next slide, please. As we work with and scan best practices across the country, and I think about the work that we do at my organization with the state of Connecticut, we're an independent nonprofit organization that supports our state system here in Connecticut to do a lot of the things that you see on the screen here today at the program level and also at the state system level. And, but we've also had great opportunities to work with states across the country who are engaged in CCBHC initiatives or mobile crisis or evidence-based treatments, and learn a lot about what's happening across the country. And certainly we see a tremendous amount of focus on equity and ensuring that you have a capacity as a state system or as a CCBHC clinic to be able to disaggregate your data and look at evidence for disparities that exist within your outcomes, within your access, within your service quality indicators. And having the data and being able to disaggregate so you can find and identify and address those areas of inequity is really important. And I think if it's not an emerging best practice, it's something that everybody should be working on and thinking about in every state. We also recognize that kids are interacting beyond just the behavioral health system, that frequently many young people are multiply system involved, and that perhaps each system's got different data collection requirements. Again, another opportunity to come together as a state system and look for areas for alignment and streamlining and efficiency. And similarly, clinics, are serving youth across a lot of different payers. So initiatives that might be relevant for Medicaid might not be asked for among children who are commercially insured. And how can we, again, look for identifying best practices that apply across payers? As we all, I think I'm probably accurate in saying we are all facing workforce challenges in every state. And one of the things when you read the literature around the workforce issue that has existed for a long time, but is now just kind of coming more to the forefront through the pandemic, is that paperwork and data is one of the things that clinicians are identifying as being a factor involved with their burnout and with their decisions to leave this field. So that conversation about streamlining and efficiency of data collection, it has real consequences and implications for the workforce challenges we're all facing. So just yet again, another reason to really invest in thinking carefully about these things. We're talking about quality in today's conversation. We here in Connecticut have invested a lot in the dissemination of evidence-based treatments in our clinics. I know it's a priority for the CCBHC initiative as well. We're investing in trauma-focused CBT and match and child-parent psychotherapy and ARC and CBITS and bounce back and a number of other things in this state. And our data is demonstrating not only that we're getting better outcomes in our EBPs compared to treatment as usual, but we're actually seeing a reduction or even a complete closing of treatment outcome disparities in our evidence-based treatments when you compare them to treatment as usual. And I'm going to show you a little bit more on that in a later slide, but that's an important point to make, that this investment in evidence-based treatments really does deliver better outcomes for all kids, and perhaps particularly for children of color. So it's a really important area for you to be working on. We also understand children are nested within families, and oftentimes states are not collecting family level identifiers, but I think that's an emerging best practices that people need to think about. Another thing that we've learned in the pandemic, we saw a lot of our clinics here in the state of Connecticut make a hard pivot from clinical service delivery to addressing basic needs. And one of the insights that was generated from that is the importance of doing a better job at the service delivery level, integrating social determinants in our social services sector with our clinical service delivery sectors. And so how can we do that? For example, in the early childhood space, where we identify early risk and address social determinants and think about social and clinical services in a more integrated fashion. And I'll move a little more quickly. I know we have a lot to cover today, but identifying issues of trauma, exposure to trauma, but also symptomatology, which tends to be cross-diagnostic for many kids. And so how are you thinking about screening for trauma within your CCBHC and within your state system? And lots of opportunities when you have the data to be able to directly translate that into provider-focused quality improvement activities. Nobody at the provider level is interested in the data black hole, where there's a requirement to collect information, it goes into a system, and then it just disappears, never to be seen or heard from again. And we want, and I think everybody, we all want to be collecting data that's going to be actionable and useful for improving services and quality. And we're seeing more of those kinds of concepts make their way into value-based payment arrangements, which we're going to see more of over time. Let's go to the next slide, please. So just to give you an example, I did hit on evidence-based treatments and some of the investments we've made here in our state. And we collected and published a study recently where we looked at implementation of trauma-focused CBT and match delivered to 46,000 children across 25 outpatient clinics. Some of those 46,000 having received one of those evidence-based treatments and others that received treatment as usual. And what we saw was a very reliable difference between the outcomes we saw in our evidence-based services versus treatment as usual. And as I mentioned earlier, also reduced disparities. So if you're interested in learning more about that information, that top right article in the Children and Youth Services Reviews, where you can learn more about that. But all that to say, invest in your evidence-based treatments. It's an opportunity for you to use the CCBHC certainly to do that work. But how can you expand and disseminate evidence-based treatments across your entire state using the platform of CCBHC? Next slide, please. And this is an example from our work from Mobile Crisis, and this kind of touches on the point about the data black hole and how you want to turn your data into actionable information for states, or rather for providers. In our mobile response initiative here in Connecticut, we've had 12 or 13 years of collecting data and information from our 14 provider sites, and then really translating that, working with our provider clinics through my organization to continually improve service delivery. So this just gives you an example of the type of things that we do in that initiative and what you can do for your individual programs within your CCBHC. So when it comes to mobile crisis, how many individuals per 1,000 were served across the different geographic breakdowns of your state? Where is utilization high and where is it low? And are there certain cities or towns where most referrals are coming from? And you get some answers to that. These are sample answers that come from those kinds of questions. But the main point here is the right side of the slide, having to do with actions. Once you identify, for example, that your schools are underutilizing your mobile crisis program, or referrals to your evidence-based treatments are low in a particular city or town or region of your state, it yields specific actions to address that issue. So that could be, let's increase our outreach to schools. Let's increase our outreach to police departments so that we were making sure that we're disrupting pipelines using our mobile crisis service system. So again, just an example of one program and how you can use your data to engage and inform practice and quality improvement. Next slide, please. And then going from the program level up to the system level, this is just an example of something where there's very timely stuff that we're working on here in our state. In addition to the individual programs and evidence-based treatments and mobile crisis and other data that we have for programs, we also are interested in, well, what's happening at the population level, what's happening at the state system level. And along the left side of this figure, you can see the categories or areas that we wanted to collect some indicators on. And then in the middle, you can see what those indicators are. These are the kinds of things at a very high level we want to be paying attention to in our state. And knowing that our CCBHC work is actually contributing to state level impact, I think is an important question, tying and connecting the individual services to the state level work that's happening. Are we addressing need and prevalence, and are we driving down rates of mental health and conditions? Do we have evidence that there's sufficient access to our services? What does our utilization look like, and where are we low? And are we still seeing too many kids presenting, for example, in emergency departments? And are we seeing too many admissions to inpatient hospitalization? Workforce is an area that, 5 years ago, I'm not sure that workforce would have made it on this dashboard, but now it's a pressing concern for everybody. And we want to be able to pay attention to a few indicators of how we're doing in that area in our state. And you may be thinking the same thing in your state as well. Costs are always certainly going to be there. How can, in this instance, for example, what is the actual cost of care at the provider level, and how does that actually relate to what's actually reimbursed at the provider level? And what does that gap look like, and what do we need to do at a policy level to address it? And then finally, all these population level outcomes that we care about in terms of rates of suicide, rates of inpatient hospitalization, involvement in multiple systems. And importantly, let's not forget along the right side, for many, many, many of these indicators at the program level, but also at the state system level, we want to be able to disaggregate our data and look at this from the lens of health equity, so that we know that the populations most in need of services, who are suffering from disproportionate outcomes in any one of these indicators, that we're taking specific action to address equity issues that exist and disparities that exist. And you can't do that if you don't have those data elements systematically collected. So let's go ahead and flip to the next slide. Hopefully that was enough to get you going and thinking about some of the major big picture issues that are out there and best practices that are taking place. And I'm really excited to introduce Carrie Virgo, and she's going to talk with you about her experience in the state of Tennessee, and then turn it over to Mandy after that. So Carrie, please take it away.
All right. Thank you so much, Jeff. It is my honor and my privilege to get to be here today representing our great state of Tennessee. Just a few things about me. I have been in the mental health field for 20 years, and I think I've done every job known to man within the field. And so I feel like I hope that I bring a very different and unique perspective to this role at the state, and being able to have a good understanding of what our community mental health centers are facing. Jeff had brought up something really important to me, specifically around burden reduction, and when asking for outcomes, not making it harder on our providers. All that to say, just wanted to share a little bit about our department today. And our department's mission is really to create collaborative pathways of resiliency, recovery, and independence for Tennesseans living with mental illness and substance use disorders. And keeping true to this mission, Tennessee has been a part of the system of care movement since 1999, when we received our very first demonstration grant. Since that time, many collaborations have grown from our system of care work, including the development of our school-based behavioral health liaison program, our certification for family support specialist, and our certification for young adult peer support specialists. We know that it's imperative for us to have a complete continuum of care that's going to ensure that children, youth, young adults, and their families will make it, will be able to receive the right service at the right time. The Office of Children, Young Adults, and Families serves Tennesseans ages 0 to 30 and is divided into 4 core areas: infant and early childhood initiatives, school-based initiatives, youth and young adult initiatives, and our system of care initiatives. In our infant and early childhood programs, this is primarily promotion, prevention, and early intervention programs. We do have a legacy program within our early childhood, and that is our Regional Intervention Program, or lovingly called RIP. This is a parent-implemented program that utilizes the pyramid model. This program has been in operation since 1969. We recognize that there is a huge importance that needs to be placed on infant and early childhood development, and our state has been fortunate to have a strong association of infant mental health that helps us support the training and education, as well as an endorsement program further professionalizing specialists in the population. Our school-based initiative programming provides services and supports for K through 12 grades. In our direct service programs, we utilize the pyramid model for K through 3 and the multi-tiered system of supports for grades 4 through 12. Within the initiative, we offer such programs as Erase the Stigma, Violence and Bullying Prevention, Respite Care, and then our school interventions, which is Project Basic and School-Based Behavioral Health Liaisons. In addition to this, we also employ a mental health consultant at the department who is providing clinical expertise as the co-director for Project Aware. For those of you who may know of Project Aware, this is a collaboration between the Department of Mental Health and the Department of Education, and it allows us to do some work within the schools from a clinical perspective. Our youth and young adult initiatives are focused on early interventions and are primarily funded by the federal dollars that we get through discretionary grants and block grants. This includes our Healthy Transition Program, Clinical High Risk for Psychosis, and the First Episode Psychosis, or FEPI programming. Our FEPI programming utilizes the on-track model and is being monitored for fidelity. We have a statewide youth and young adult leadership council that provides us guidance in regards to policy and planning. And as of May 2021, we now have a certification program for young adult peers. Lastly, our system of care initiative really focuses primarily on those deep end intervention services and utilizes intensive care coordination using a wraparound approach. We have been using high fidelity wraparound in the state of Tennessee for the last 5 years. This is a program that continues to expand. When we began that program 6 years ago, we had 4 sites. Today we have 32. We're really proud of that. Housed under the system of care also lives our certification for family support specialists, as well as our statewide family support network. Within the department, but outside of the Office of Children, Young Adults, and Families, we also have some other programs, one of those being our Children's Behavioral Health Safety Net. This program is allowing those who are uninsured to still receive services regardless of that insurance. In addition, our crisis and suicide prevention services, we have a juvenile justice office and substance abuse programming for children, as well as our early intervention system for children with parents who have substance abuse concerns. Through the department, we strive to ensure that there's a solid continuum. However, we know that it's not possible for us to serve all needs in all areas, and therefore it's imperative that we have good, healthy relationships with our providers, other state agencies, and community stakeholders that can assist us in getting families what they need. Operating under system of care values, we embrace the community-based principle, and we want to partner through mutually referring and resource sharing in local communities where families are at. We know that we're better together, and through networking, we attempt to link what communities already have and use data to assist and obtaining funding to fill the gaps. Like most states, Tennessee struggles with access in rural areas. Tennessee is quite different across the length of the state. It takes 3 hours to get from north to south, but it takes 9 hours to go east to west. And across that 9-hour span, you have mountains all the way to rural farmland. And so as you can imagine, like most states, we might have some issues with transportation as well as connectivity in some of our rural areas. And so we are really focused on partnering as much as we possibly can to ensure that families are getting what they need wherever they are in Tennessee. As a result of the pandemic, we do know that there has been an increased use in telehealth, and that has really opened the door for us to be able to partner differently with our families and continue those services even when we may not be able to meet face to face. It has definitely made a huge impact throughout the course of the pandemic and being able to continue to move our families forward and get the services and supports that they need. Lastly, I think it's important to note that as we continue to move forward in the mental health crisis that we're in currently, we need to pay attention to two things in particular. One is that we need to be able to partner with anyone and everyone to get folks what they need. And the second is services and supports that are well measured and show improvement need to be our standard of care as they produce results and decrease disparities in care. Next slide, please. One of the values of the Tennessee Department of Mental Health and Substance Abuse is that we are solutions and outcomes oriented. This is a value that I hold very near and dear to my heart, and one that has been proven time again as the linchpin to us being able to expand and implement quality services and supports. In Tennessee, data just drives all of our decision making. If our data begins to signify that there's a process issue, we will work with our providers to address it immediately. We make data known to our providers, communities, and stakeholders so that we're ensuring transparency and integrity of how we are stewarding the tax dollars. Each of our programs has a battery of measures that occur based on the evidence-informed or evidence-based model that is being used. Many of our measures align with those of the CCBHC demonstration and are monitored based on the specific program. We're fortunate in the department that we have an Office of Research which houses 3 research specialists who are able to help us measure our programs. Some of our federally funded programs also provide for an evaluation component, and we have partnerships with Centerstone's Research Institute and Vanderbilt University Medical Center to assist us in more wide-scale data collection as well as fidelity monitoring. If there is an opportunity to monitor for fidelity, that is something that we want to continue to do, and we're always going to promote those evidence-based, evidence-informed practices before any other that we partner with. Within the department, we use measures like the IBERG Child Behavior Inventory, the National Outcome Measure, or NOMS, the Columbia Impairment Scale, the Child and Adolescent Needs and Strengths, or CANS, the Caregiver Strain, and many others. Based on the strength of the data we collect and our ability to take programming to scale, we've been able to show the real needs of the children and their families in Tennessee. In the last 3 fiscal years, we have been awarded an additional $18+ million annually to support our children, youth, young adults. And additionally, in FY22, Governor Lee and the General Assembly made a $250 million investment in our K-12 Mental Health Trust Fund, which will allow our department to use the dividends to expand school-based services even further than they are now. We currently have at least 1 liaison in all 95 counties, and we are hoping to continue to take that on even further. It is because of our strong collaborations with our partners, our proven track record of effectiveness, and the ability to support it with data that allows Tennessee to continue to make investments in the future of our youngest citizens. Next slide, please. This is just a couple quick examples. I didn't want to go into too much detail here, but wanted to give you just a snapshot of some of the dashboards that we're using with our providers. So as an example of our data, I want to show you our sample from our system of care across Tennessee. And this is our keeping kids at home data. This would be the graphic on your left. This is a dashboard that we share with our community providers monthly. This allows our providers an opportunity to see how they're doing and how they can compare themselves to how others are doing. As of today, I'm happy to tell you 5 years into high fidelity wraparound implementation, we are keeping 93% of our kids in their homes. So that was real exciting and wanted to share that. The second data set on the right-hand side of the screen is a data dashboard for one of our community providers, and this is their quarterly dashboard for their first episode psychosis team. And as you can see, their interventions led to improved functioning across those that they were serving. So overall, I hope that you can see that Tennessee is very data-driven, and we always want to continue to improve. We want to continue to partner. We want to do what's right for the children and families of our state and really get them the right services at the right time. On that note, I am going to turn it over to Mandy Ryan, the Vice President of Healthcare Integration at Centerstone.
Thanks, Carrie. I'm so glad to be with y'all today and be able to talk about CCBHC and kind of where we started and where we are today. Just a little background, like Samantha had said, we are a pretty large nonprofit private organization that's across 4 states. We've had over 60 years in operation and we're COF accredited. We're located in Indiana, Illinois, Florida, and Tennessee. For our states, the only 2 states that the states had actually applied to be part of CCBHC initially was in Indiana and Illinois, but those states were not selected initially to be as CCBHCs, but they were 2 of the part of the states that initially were able to apply for SAMHSA grants for CCBHCs. And proud to say that Illinois state has now decided to move in the direction of becoming a CCBHC. And that's in Indiana, and then Illinois, they're in talks of it. And then Florida and Tennessee, we have not got there quite yet, but I'll kind of talk about where we are in Tennessee and how we've used data to help us along the way. Next slide, please. So what Tennessee decided to do is they had really been looking back in 2014 at what were some of the models that were out there. And at that time, health homes were a model that was out there. CCBHCs, were still in talks at that time and wasn't as seen as the national landscape quite yet. So Tennessee decided to move in the direction of health homes. They looked at primary and behavioral health care transformation. It took them a couple of years as they started plotting and seeing where those were going to go. And in 2016, they moved in that direction. So all of our primary care in Tennessee has the option to move to patient-centered medical homes and get that accreditation. What they did for the Medicaid population for behavioral health organizations is they moved away from case management that we had typically provided to our clients, and they transitioned to health homes for severe and persistent mental health and serious emotional disturbance. So we were no longer able to provide our typical case management like we had done for many years. We all had to move over to that health home model. Part of CCBHC, the care coordination aspect of CCBHC covers all of those activities that you do in health homes. So we moved away from the payment model of how we had been paid before, and we moved to a case rate, and we moved to being having outcome performance measures that we were expected to meet, and for those we could earn quality stars and efficiency stars and be eligible for an additional outcome performance payments each year for those. One of the things the state also did is they felt it was very important for our hospitals and emergency rooms to really provide us with alerts, discharges, and transfers. So they worked really hard across the whole state and were able to get all hospitals, medical, psychiatric, and ERs over years to be able to move to their care coordination tool that they have, and they send daily at the time of alerts. So we normally get those numerous times throughout the day, letting us know any of our clients that are assigned to us in a health home anytime they go to the hospital or to the emergency room. So that has been very great information that we've been able to receive based on the health homes. Next slide, please. So like I said, we were not eligible to apply for CCBHC grants initially. The first time that Tennessee became eligible to apply was in the 2020. And we were the first organization within the state of Tennessee to apply for a CCBHC and be awarded. As you can see, this was during the height of the pandemic. We were supposed to be awarded these grants to start in September, and we got notification, I think, mid-April that they were going to go live and start on May 1st. We're very happy to go ahead and get started on that. As everybody was still just in the height of the pandemic. The location that we had in Centerstone is one of, that we have our CCBHC grant, is one of our larger clinics. As you can see over this 2-year span, we served about 8,500 clients. 6,500 of those are adults, while 2,000 of those are children and adolescents. During this time, we enrolled 1,005 into our CCBHC grant. 830 of those were adults, and 175 of those were children and adolescents. We are still providing our health home services through all of our locations. We have about 20 locations of those throughout our Tennessee footprint, and we serve about 6,000 adults and children. About 1/3 of those are children and adolescents that we serve, providing many of the characteristics of the CCBHC grant through the health home. Next slide, please. So one of the things as we began looking at CCBHC, health homes, how are we going to do our metrics? How are we going to look at determining how do we build all of these quality metrics into our system without, like they said, causing our clinicians to have overwork, to have additional workloads. We don't want to create more burdens for them, but we do feel it's very important for us to be able to monitor and look at quality. So there's 3 kinds of metrics that you kind of want to look at, and there's different ways that you're able to provide the work for those. So the first thing is like structural metrics. So these are metrics that you want to just be embedded and be within your workflow. So some of the measures that we are held accountable for are related to, are you able to get patients into your clinic 7 days after a hospitalization for psychiatric visits? So one of the things that we had to do in our system was, are we making sure that we're scheduling everybody but prior to the 7 days? Obviously, if you're scheduling individuals after the 7 days, you're not going to meet this metric. But how quickly can we get individuals in? Can we move it to where we can get individuals in within 3 to 5 days? So if they do miss that first appointment, you're able to also get that individual in maybe for a rescheduling before. Is it good to do walk-in clinics for your hospital discharges to make sure that those individuals are coming in to your clinics? So we've made sure that for some of those structural metrics, that our workflows and how we provide that care was initially. So when individuals call in to make that appointment, we know those appointments have to be in. So we're going to look for those appointments to begin with. Other things that we would do for workflows is making sure that it's easy for us to be able to identify individuals who are in CCBHC or maybe in our health home. So we put in our electronic health record. In our electronic health record now, all those individuals turn green. So their name's in green. They're highlighted with an H to say they're part of our health home. So it's very identifying that those are members, and we can easily see these members are our members that we want to make sure that we're providing those activities and making sure that we're getting them into those appointments at that needed time. Another thing you can do for those embedded workflows is how can you ensure those individuals are coming into those appointments sooner? So one thing we did was we embedded hospital liaisons within the hospital so they could see individuals prior to their discharge to make sure that they had that warm handoff. This is the agency that you're going to go to. We want to make sure that you're going to be able to attend this appointment. Here's my business card, and you can reach out to me if there's some kind of difficulty before you come to that appointment. And that's been really helpful, especially to new clients as well as our existing clients who may go into one of our psychiatric hospitals within the state. The next thing you want to look at are some process metrics. So these are some of the screenings or assessments that you're currently doing. Having those embedded into your electronic health record is very important. So it's just very easily for the clinician to be able to do that. You can easily set up some pre-screening questions to where if the client screens positive for the pre-screening, one of those automatic screening tools that you need would then pop up on the screen so the clinician is able to complete that. That has really been helpful for us for any of those screening measures that you need is what ways are you able to do that? So we've used a couple different electronic health records. We just now switched within the past year to Avatar, which is part of NetSmart. Previously, we had an electronic health record that was one of Qualifax that we had actually used for many, many years. Other things that you want to make sure is that any of the screenings that you have to do. So sometimes with quality measures, you have lab work that clients need to do. You need to check for our individuals that may have diabetes, or maybe some of the children are you're doing the whole metabolic monitoring where you're looking at cholesterol as well as diabetes, is have that process automatically into your system where your clinician will get an alert that it's time for their yearly. So they will make sure those labs are ordered, and then that you're reporting on those within your electronic health record so they can go out on claims. For us, that was new. We had never, ever been able to, we'd always drawn labs, we had always checked blood pressures, but we never actually put them on our claims. And that was a new move that we had to invest in order for that documentation to then make it to our managed care, our Medicaid population. So we would, they would be able to see all of the work that we're doing. And having that where your system reminds you, your system makes it easier. It makes it where you have all of these quality measures that you're having to report on, but you have a system in place that moves them along. So then you're not having to constantly keep up with that through Excel spreadsheets or tracking. The process is working to where you're going to get alerts as well as other kinds of tools to help clinicians. So hopefully that burdensome is not so much for the client. Another measure you want to look at is some of those outcome metrics. So that's going to be more of your symptom control. Are you decreasing the blood pressure? Are you decreasing the diabetes? So you have to be able to know what that measure is to be able to know if you're actually decreasing that. So having that easily seen in your record, but also going onto your claims is a way that the payers as well as yourself can move in that direction. Next slide, please. So, as you were looking at your data, each state is going to be at a different level. Each CCBHC is going to be at a different level, but there's a lot of data that you're already collecting that can help you paint stories and help you talk to your payers, to your state, encouraging them to see the results that you are getting from your CCBHC grant. So as a lot of you know, we collect a lot of NOMS data from our clients, and from there you can get a lot of outcomes out of SPARs that you can be able to share with the clients. You can share with, we do an advisory council every 6 months where we bring individuals in from clients, family members, other stakeholders, and be able to share the data and the improvements that we're being able to see with our kids, with our adolescents. And so this is just like some SPARS data that we've collected over time. And you can show how are individuals improving from this, and you know, some of the things that they're doing. So it's some of the measures that, you know, really make a difference in our child's life. And these are great ways that you can be able to tell stories to determine how successful the kids and adolescents are doing within your program. Next slide, please. So we also, like I said, had state outcomes, which are very similar to the CCBHC standards. A lot of them are very similar to the ones you have. And these are the outcomes that we've been able to obtain through our health home every year since the program has initiated. We have been very successful with this. We've been able to receive outcome performance payment from all 3 of our MCOs that we have in Tennessee that are Medicaid each year, showing the different quality measures that we've been able to exceed benchmark. Here are just a few examples of what we've been able to help do with meeting these measures with children and adolescents. Like I said, our health homes have adults too, so we have other measures that are more specific to adults. But like I said, follow up after a hospitalization for mental illness, you know, 7 and 30-day readmission rates, making sure you're below the benchmark for that one, and then above for that. You have to have those system processes embedded within your workflow in order to make sure that you are having individuals scheduled for those appointments and then coming in, and that is being sent out on your claims so you're able to meet those. The use of multiple concurrent antipsychotics in children and adolescents, you want to make sure that your providers are educated on when it's appropriate to do this and when it's not. So then that is a measure that you're able to meet. The BMI and waist assessment, that was a new measure for us. We had never reported BMI before. We would take individuals' weight and height, but we never calculated the BMI. We never put that on our claims. And that was a requirement that we needed to do in order for us to help meet this measure. And so we put changes into our electronic health record to allow us to do that. Like I said, metabolic monitoring for children and adolescents on antipsychotics, we are able to have system requirements in place that have our med providers checking on that on at least an annual basis. They get reminded of that to make sure, so they are able to do that where it's not as much of a issue for our care coordinators to assist with that, because our med providers are ordering it. We can, you know, do lab draws within house, or if we don't have that availability in some of our rural clinics, then we can set up partnerships with labs to be able to send our clients to those. Another measure we had to do was EPSDT, well child visits for different age groups, and making sure that those individuals receive those services. So those were partnerships where we would work with their primary care physician, their pediatrician, and making sure that those individuals attended those appointments on a yearly basis. So even though that is a measure that we cannot directly provide the service, we can work with another provider in order to ensure that our clients are going to those appointments, as well as getting that information to us so we know that they've attended. As you're working with your states, some of your states may not have moved to this direction where they have quality measures that you're looking at. Prior to our states moving to this, one of the things that we did is we would work with each of our different payers to say, what kind of data are you interested in? What areas are you wanting to improve? Can you send us that data for our clients so we can help you with that measures. Most Medicaid agencies do have HEDIS measures that they're held accountable for us too. And so requesting that information from them is a way that you can start learning to do some of these activities prior to your state moving in that direction. We asked for hospitalization alerts. Now, a lot of that's claimed data, so it was delayed, but it was a way for us to look at this information initially and be able to move in that direction. Next slide, please. So the last things I want to talk about is sometimes your state may move in that direction and you have data you have to, but just with CCBHC, there is information that you can pull out of your electronic health record. So we have an analytics department that helps us pull information. So we've been able to pull scorecards and dashboards that we can create to help clinicians see vitals, see future appointments, history, all the metabolic monitoring. Next slide, please. And this is my last slide. You can look at client suicides, suicide attempts, that hospital utilization, and even AIMS data. So there's all kinds of information that could be embedded within your EHR that your providers, your departments could help you pull that data out to help you tell a story. And that's kind of the direction you want to go, is what story can I tell? What successes can I show with the data that I currently have? So I think we want to be able to have an opportunity for some questions. You can move to the next slide and I'll turn it over to Samantha. And I'm sure you've gotten some questions coming in for the group.
We have. Thank you so much to all of our presenters. It's incredible how much we just packed into 50 minutes. So big kudos to all of you. For anyone on the line, again, feel free to send along via the chat any questions you have. There were some that came up that even got answered almost in real time. Maybe we'll start off though. There was quite a bit of mention around cross-sector partnerships. And I'm just wondering, I'm thinking about the CCBHCs on the line who are earlier in this journey and opening it up to all of you. What recommendations might you have for what other agencies or systems they should be prioritizing collaborating with to explore data collection and sharing opportunities to drive outcomes specifically in the child serving system space?
I guess I'll kick it off, but I'd love to hear what Andy and Carrie have to say on that. Just a couple of things that come to mind in the child serving space. I think, and Tennessee can speak to this because I know they have a number of initiatives in school mental health, but I really think education and schools are a critical place in terms of a referral source, but also a partner you need to speak with. Many of the measures, I think certainly a case could be made for having a strong relationship with your pediatric primary care community. That would be another community. And then the third thing I would mention, with maybe it will sound a little bit surprising to you, but I hope not, when it comes to the data elements that you're collecting, how you're collecting them and how you're reporting them back, don't forget your parents and your family members. I think they can be really important partners in helping set the agenda in terms of what's important to be looking at, and can even be part of the process of reporting data back into the system and making meaning out of that data.
Mandy, did you want to talk about the early implementers part of that? Because I've got lots of ideas on cross collaboration, but.
Yeah, so like I said, one of the things that we did prior to getting any of the state data and our state moving to a health home was really partnering with your Medicaid partners that you have in your state already and seeing what data can you give to them. Now, it takes a minute to do that. It's not something that's quick and overnight, but if you can get with them and find out what is it that they're interested in learning about or improving, and then you make a difference with them in helping improving that measure, then they're going to be so much more open to providing more information and more data to you. Some of it's even more data than you could even imagine to go through, but showing that that interest with them. A lot of times, if you can see that what they're interested in, and then from there, they then move in helping you. Also, if you're not receiving those alerts from hospitals, sometimes you can partner with the hospitals to say, my patients are coming in, can you let me know? We can help prevent them from coming back. Hospitals, are held accountable when they have patients being readmitted quicker. So they a lot of times will give you that data. Working with your primary care office also, like Jeff said, is very important. They'll be able to help you with some of those measures because a lot of them are held accountable for those same kind of measures, and they'll work with you in order to help collaborate those together.
I agree with all of the above. And I would also, thinking about it, I mean, Mandy, those are the people that you need to start talking to early and often. You brought up a good point. It's always about the win-win. It really is, because Mandy's correct. As a state level person, there are certain things that I'm held accountable for that I have to show. And so those things are already things that I'm looking at. And if we can mutually have a beneficial relationship where I can give you the data that you need and vice versa, then that is a beautiful thing. I tell our folks all the time, 95% of your job is relationship. And the reality of it is, if people like you, they're going to probably be more inclined to help you out or help you figure out how to get around some barriers. I was thinking about it just from a state perspective. You've just got to kind of really know your state well and know who the players are and take the time to build the relationships, because there's probably something that you both need out of that relationship. And it's ultimately just reminding folks that at the end of every single dollar is a family. And so we need to do the right thing by our families. And so in order to do that, we've got to talk to each other. There is a power in a cup of coffee, y'all. So take some time and just get to know people and be like, there's going to be certain things that state folks cannot give you. There's just things that they can't. And there's things that we can. And so it's like, all right, let's have some discussion about what can we come up with. Are there other data sources? Because I'll tell you, we can't possibly at the state level have every piece of data you could possibly want. And a lot of the time, we're going to outside sources too, things like the Annie E. Casey Kids Count and things like that. And so we use a lot of those things in writing our grants. But the reality is we're all on the same page trying to do the same thing. So relationship.
I couldn't agree more. I talk about this all the time. So I feel like I really found my people with all of you, because you love data. And then you also talk about the fact that you need to communicate that data to many places. And Carrie, you already started kind of answering another question that was bubbling up on this end, which is, it was really great to see the data that you make available to providers. We know that is not the case for everyone, right? And I was asking a little bit about what recommendations you might have for clinics hoping to engage in better data sharing with their state agencies. So you just said a few things, right? Finding that common ground, building the relationships. Anything else from your lens, or Mandy or Jeff too?
I mean, I think predominantly that's it. I think you need to take the time to invest into the relationship and figure out what you both need, because you both need stuff. And so, figuring out what that common ground is, how do I create a win-win? Because the reality is I want to make your life easier and vice versa. So what does that look like? You also need to understand how your state is set up, because everything is a little bit different depending on your state. And so in some states, like I come from Indiana, I know that the Medicaid authority is within the Department of Mental Health. That is not the case in Tennessee. It is a completely separate agency. And so you need to understand, are your schools a unified district? Are they all separate districts? That changes what data you can and can't collect. And so you just need to get a real good landscape of what your state looks like. And, find those people that can really help hook you up and be like, okay, who do you know in this area? So, Mandy, go ahead.
And then you have to make sure you use the data that they give you. and then show them how you used it. That can be a big barrier if they give you a lot of data and then you don't utilize it or show them how it helped you. They're not going to be as eager to share more data with you. And so any data that you can get, then show how you're going to use that and then what impact that can make. And showing them the data you're already collecting and some of the outcomes internally that you're already collecting. Utilize some of the measures that are part of CCBHC to say, look, these are some of the areas that we know is important for children and quality reporting. And here's some of the ways that we can start collecting it, but here's some of the other information we might need from you. And then show some of the results that you've already gotten just from the limited data you have. That will make an impact on how they want to share with you and kind of the direction they're wanting to go.
These are all great insights. We are right at time. So I think we don't have time for any more questions, but I want to give you all a huge thank you and really appreciate everyone who showed up today to participate. As a reminder, you'll be able to access the recording and the slides in the UMD LMS. And that's all we have for today, and we can't wait to see you in 2 weeks for care coordination. Thank you, everyone.
Thank you for joining this month's Child and Family Focused Certified Community Behavioral Health Clinics Learning Community, hosted by the CCBHC Expansion Grantee National Training and Technical Assistance Center. Please take a few moments to complete the evaluation for this workshop using the following link being posted in the chat. We will be providing a certificate of attendance for completion of each workshop being offered throughout the entire series. So make sure you're registered with the same name logged into each webinar so that we can confirm your attendance and the total time you were part of this workshop. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and webinar recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all the upcoming and previously recorded webinars. With our goal to support increased access to and improve quality of CCBHCs in meeting the needs of youth and families, we hope you join us for care coordination, a key component of the service array for youth and families. I hope that today's session has provided you with greater understanding of the value of children's services and the role of child-serving systems as you continue to identify and implement approaches to meet the unique needs of children, youth, and young adults with behavioral health needs and their families.